Hello, everyone, and welcome to Africa Fire Mission's weekly virtual training session. My name is Mike, and I'm the programs director here at Africa Fire Mission, and I'm so happy that you all took time out of your busy schedules to join us for today's training. Today, we're joined by Richard Gichina. Richard is one of our volunteer fire safety advocates, and he's been doing some instructing for us. You may have seen him teaching some classes on here previously, so we're very grateful that he's joining us to lead us in today's training. Before we get started, just a couple of administrative items. If you stick around for at least 70% of today's training, which is usually about 40 or 45 minutes, you'll receive a certificate of attendance for today's training. If you can't stick around for the whole thing, or if you've missed any of our trainings from earlier in the year, keep an eye on the chat where I'm going to post a link to our Google Drive where you can find a recording of today's training and all of the other trainings that we've done previously this year. If you watch the video, answer a few questions about what you learned, I can send you a certificate of attendance for those classes as well. Before we get started with today's training, I'm going to pass things over to Jose Nanjiri. Jose is Africa Fire Mission's Fire Safety Officer, and he's going to share a few words of encouragement.
Thanks, Chief Mike. I truly appreciate you. And Richard, thank you for joining us today. We are grateful to have you. So one thing has been running through my mind this week, and it was about just our mental health, even as first responders. We are going through, in Kenya, we're going through a very tough time whereby we're just getting floods, buildings are falling down, and sometimes you might feel helpless. So the thought that came into my mind was just being hopeful. So I ended up going into the internet, of course, to see what are the things that will help me and help us as first responders to continue being hopeful amidst a lot of challenges, especially what we're having here in Kenya. And I remember sometime in Malawi, there was also some very heavy rains and there was some mudslides and things like that. So how do we get to be hopeful? So I'll just give some 3 points and then I will copy and paste on our chat more items that you can get to follow in your time. Number 1, control what you can. What do I mean? For example, if there's a lot of water and you feel that you really need to go and help, sometimes don't try and be Superman to go and help people and actually things are out of control. If you can control maybe throwing a rope or just asking people to get away from the water, that is actually what you can control. Whatever is above you, forget about it. Number 2, you need to combat your negative thoughts. You might feel so stressed, you might feel really worked out. Those are negative thoughts that are coming into you as a first responder and as a firefighter. But just remain calm and tell yourself these thoughts are not going to be engulf me. And the last one, the 3 items, check out your spirituality. It's time for you to connect with your God. Us as Christians, we connect with Jesus and ask Jesus to actually help us to calm us down and make everything right for us. So get down on your knees, pray, have your quiet time for you to get that hope back into you. Thank you so much, Mike. The rest of the items, you can look them up. I'll post them on the chat and you can get to see how you can continue being hopeful in your world of being a first responder. Back to you, Chief Mike.
Thank you so much, Jose. We always appreciate those words of encouragement and all the work that you've been doing to help assist all of the firefighters throughout Africa. I'll invite everyone to stick around we'll wrap up the formal portion of our training at the top of the hour. And afterwards, we're going to have tea time. Tea time is hosted by Jose, and it's a time where you can ask questions about today's class, or you can discuss anything else that may be on your mind. So now, without further ado, I'm going to pass things on to Richard to get us started with today's training. Take it away, Richard.
Thank you so very much. Today we are learning the general principles on a first aid, airway, breathing, and nerve systems, or the nervous system. Is what we are trying to understand today. We'll pass by so many things here and there. We'll learn. Mine is to just tell you, feel free to share what you have on the text. You can do a chart, so that by the end of the day, we can be able to understand the next. So number one, we need to understand what are the emergencies. Some of these emergencies that we have, number one, for any emergency, we need to do a very good assessment. Number two, in everything that we do, we have critical aspects. We have today, the critical aspects today, we are going to look at breathing. We are going to see what are some of the complications that comes along breathing. We're going to see some of these complications that comes up with the nervous
Richard, we're losing you again there. We've got, looks like your network's not...
Most of the organs, because we don't use balance to send in air. Can you hear me now well?
Okay, we've got you back.
Yeah, sure, sorry. So here we have the general area of a human being. We have the nose, the pharynx, the larynx, the bronchi, the lungs, and the diaphragm. In this photo, in this side picture, you can see the alveolus. These are now the airway is divided into two parts. Now we have the upper airway and the lower airway. The upper airway consists of the nose, the larynx, the pharynx, the epiglottis, and the part of the trachea. So here it is. So generally, breathing comes in when the diaphragm contracts or moves down. That's where now, when you breathe in, you always notice your chest becomes enlarges a little bit, and then the diaphragm goes down, and then we breathe. That's how the air goes. That's just pharmacokinetics, or what happens with that. When the diaphragm relaxes and the chest compresses, we breathe out the air. So here it is. This is what we are saying. When you breathe in, the chest seems to expand. When you breathe out, the chest seems to contract. So this is when you breathe in, the diaphragm goes down. When you breathe out, the diaphragm comes up. When there's movement of air inside and outside and inside the lungs and outside the lungs, that's when we are breathing. So we inhale oxygen in particular, and then we exhale some amount of oxygen plus other gases that are not used in the body. So airway obstruction structures, they might be smaller depending to the size of individuals, from babies all the way to adults. The airways or the structures of the airway, they grow as you grow bigger. Also, the lungs, the larynx, they grow with you. For men, we always have what we call the voice box. It's part of also of the breathing system. So we have the tongue, which takes more space more space. We have the trachea, which is a flexible cord. In children, in children's infant airway or breathing problems, they are #1 causes of cardiac arrest. So that's when we say if you ever come across the kids, you always find out you're always advised to do breaths first, and then we do chest compression. For adult, we do the opposite. We start with chest compressions, and we do airway. So in any patient that you always find that you always come around, the first thing that we need to do is check their airway. If the patient is talking, if they can talk to you, it means the airways are open. If that patient can nod, and then you'll find there's some of these things that you're going to see in the next slides on the effects on how you can be able to know the airway, if an airway is obstructed or not. So #1, when we are unconscious, the tongue is a #1 cause of airway obstruction because the tongue is a muscle. So if you're unconscious, the tongue will fall back to the back of the mouth, and then it causes obstruction. And the best way, if the patient has, or if your victim who you have is suspected to have had any kind of trauma or any injury, or they fell down and you're not there, the best thing you can do is jaw thrust. Jaw thrust means you hold on the jaw and then you push them forward. For head tilt, chin lift maneuver, these are victims that we don't suspect that they have any injury or they have been involved in any kind pharmacological or kinetic energy, like they have not hit their back, they have not fallen. Generally, they haven't fallen down. So these are some of factors that will affect. #1, we can say they're life-threatening. The airway obstruction is a physical, some can be physical blockage, which means the victim might be eating a piece of meat on the local butchers, on the local hotels, and then a piece of meat just obstruct the airway. The other thing is might be car accident, motor vehicle accident, or what we call the RTS. It is common for some of the patients because they will hit the head, they will hit the neck, and then some of them you will find them with trauma to the neck. It means the trachea can be deviated, or they can have some blood that they were bleeding from either from internal bleeding or from the mouth, and then it goes back. The one thing that we need to know, if the victim or the patient is not breathing, it's a life-threatening. What do we do? We said on the previous slide that we can either use the jaw thrust maneuver or the head chin lift maneuver. The epiglottis is what is found behind on the mouth. Its normal things is to prevent food when we are swallowing or when we are eating, so it doesn't go to the trachea. For unresponsive victims, the reflux or what we call the reflux mechanism can be functioning or not functioning. So which means if you try to open the air using some of things that some devices that you're going to learn ahead of time, either the NOP or the oropharyngeal or the nasopharyngeal airway adjuncts, you'll notice like some of these patients, if you try to use it, they will tend to vomit. That is what the reflux, it is what that triggers normal human body to want to vomit. Unresponsive patient may lie back, vomit may flow back to the throat, and they can block or limit expirations. So we're going to see how we deal with that. Then generally after opening the airways, the patient, we need to clear the fluids or any solid. The fluids might be saliva, blood. We have maybe they were drinking something, you try to clear that, or solid, they might be, they were talking for a piece of meat or the dentures, some of our patients might have a big chunks of meat that are attached on the, like can block their airway. So here it is. This is just a small how to check airway. Please, you with your gloved hand. Remember we said safety is paramount with your gloved hand. That's why we you try to open the airway. When you're clearing or when you are trying to clear using a finger sweep or a suction, number one, you need to make sure you can see, you can visualize what has happened to the victim. Can you see the block or the blockage? Can you see the fallen body? Can you see the piece of meat? Can you see the piece of bean? Can you see what you only finger sweep, or you sweep by your finger with what exactly you can see? So the other thing we're moving out is, yeah, this is what we are trying to say. Make sure you see what you're trying to remove. Then you can roll the patient to the left. That's when we are performing the patient recovery position. So when the patient is supine, the airway may be opened by either the head tilt or chin lift maneuver or the jaw thrust maneuver. Airway adjuncts can be used what we call the oropharyngeal airways or nasopharyngeal airways. Oropharyngeal airways just go through the mouth. The nasopharyngeal, they go from the nostril. They go from, you put them through the nostril. And how do you measure them? You measure from the tip of the mouth. If you are doing the oropharyngeal, you do from the tip of the mouth to the earlobe. Then the other part is if you're using the nasopharyngeal, you get from the tip of the nose or where the nose string starts or ends to the earlobe. That's where you get the patient. So here is how to put the patient into recovery positions. Number one, if you want to, the reason why we do a patient recovery position is very simple. It helps the patient keep the airway open, because if they are sleeping supine or they are sleeping using their back, the tongue may fall down and it may block. Then they may vomit, and those vomiters will go back, will tend to go back. Then if the patient is vomiting, the fluid will flow down. It prevents aspirations. It is if it's possible, the victim is left. Mostly you tell them, let them lie to the left if it is possible. If it's not possible, take them to the right. The other thing is we need to continue monitoring breathing. So this is the head tilt chin lift maneuver. You put your one hand on the forehead, and then you get your two fingers and lift the chin. That's why it's so the lift the chin and tilt the head backwards. The head tilt, chin lift, head tilt backwards. So it helps you to put the airway open. For breathing, adequate breathing, it's between some of these books that you find, they'll tell you it's between some books will tell you it's between 8 to 12, and there are books that will say it is 10 to 16, depending with your level of practice. How do you know if the patient is breathing? This is when you check the movement of the chest or car. If the chest is moving up and down, and you can put your two fingers across their nostril, if you can feel some warm air getting out and some cold air getting in, it means the patient is breathing. The other thing is, if you have the stethoscopes, you can be able to listen. You can be able to listen with the stethoscope. Some reflex gaps may be present just after cardiac arrest. When you're doing normal breathing, if you're doing normal breathing, breathing should not be labored. It should be effortless. It should be normal breathing. Then we have people who, when the airway is obstructed, they produce some sounds. Then can you notice from the known to unknown, what you know and what I see in myself, is it normal to what the patient is exhibiting? Like if my breaths are silent and they don't have noises. So I always assume that the patient should have the same. So we continue doing that. So then we have respiratory emergencies. We're going to pass through some of them. We have respiratory arrest and we have respiratory distress. So signs and symptoms of respiratory distress. These are some examples. They're gasping of air. The patient is or the victim is trying to gasp for air. The breathing is fast or very low than normal. They have sounds. They have whistling sounds, or they have other sounds. The breaths. We saw earlier, like the breath should be normal and non-labored. Most of you find them using the accessory muscles. We're going to see in the next few slides how accessory muscles affect. So you'll find them very disoriented. They have altered mental status because the oxygen is not reaching to their heads. Then we have the skins change from pale blue, cool and moist. They become cyanotic. Then you have shortness of breath. Then you have noise, breathing. You always find them, like, for example, when you're running, you always have an ability to speak a full sentence at a go. Here it is. We have also signs. As we continue with signs, we have you find out like the nasal flaring is when you can see their nostrils are enlarging and smaller and contracting. I don't know if you have. It happens mostly in rabbits. They will tell you like they feel their chest are very tight. Then they will have cough, crowing, or high pitched bark. That's when they're trying to cough, and you'll feel them. They will cough at high age. Then most of the time you find your patients or your casualties being on a tripod position. These are some of the signs that will give you details of how if the patient is breathing well or not breathing well. So this is what we were saying about the use of the muscles or the utility muscles. You see, if we look at this patch of this baby, it forms like an arc. And you see they're trying to use their muscles to breathe. They're using the neck muscles, the chest muscles to breathe. And you'll find them, they have nasal flaring. And you try to them like they are trying to reach up on for air. These conditions are most of these conditions are they said that their life are threatening. So what happens is if you find in time, they will try to do a lot of labor, and you'll find these patients tired. You'll find them not doing well. So we said, remember, each and every patient that has difficulties with breathing, we need to take them to hospital. So this is what we are trying to say. We are trying to define respiratory arrest. These are inadequate breaths, and their life threatening. The other thing is respiratory arrest. Patient is not breathing at all. Inadequate breathing. patient is breathing too slowly or too weak. Most of these patients, 90% of their high chances that the patient will have altered mental status. They might not understand where they are. They might not be able to truly cognize exactly what is happening in the environment. These patients need support to the oxygen. So for infants, we need to present themselves. They have the sense of breathing, then have slow but very adequate. We know for babies or infants, they breathe so fast. So then after we do that, we learn about ventilations. This is when you give the patient oxygen, is what we are trying to ventilate. In firefighters, we know ventilation is removal. It can be removal of smoke through ventilating machines or through natural vents. So if the patient has no pulse, ventilation and combined with chest compression, this means you give breaths as you do CPR, or what you call cardiopulmonary resuscitation. If you have these special equipments, you have some of these special equipments that deals with naturally they deal with they can give compression, and they can also do give oxygen. So we have some of these devices that we have. We have the mask barrier, and currently it has been we have had some of these talks that it should be removed or not. They should not be used in giving breaths, because we have a lot of communicable diseases that are happening. For example, we had COVID. We have tuberculosis that can pass. We also have hepatitis. It can be passed through our blood or body fluids. That's how it looks like. Then you have the face mask. You always find them with, I don't know if people with, most of the guys from Red Cross, they used to have this one, Red Cross St. John ambulance. They used to have some of this. And it works well. So that's how you do. If you want to use it, you form something like an A. We have this P, and then we have the three fingers that form in a C. Then you press the mask corresponding. There's one side that works well, that goes to the nose, to the nose bone, and the other one side goes to the cheek. So what you do, you hold the thumb and the thumb and the index finger, you form a C, and then the three fingers will form an E, and the index and the thumb, they hold the mask downwards, while the three fingers open the airway. They always assist you to open the airway of the victim. So that's what we're trying to see. We do it. Then we have, now these are barriers that are not available. Some of these are some of the disadvantages for using you don't have a barrier. Number one, we say they risk disease transmission. We say so much of them. Mouth to mouth, it is not. We remember this was phased out, but we have people. You can do it to people who you trust, maybe your kid's wife. So we have. Sorry, this one is supposed to be John. So these are skills. So we have severe airway obstruction. The victim is getting no air. Victims will soon become responsible. This is what we are talking about. The patient was eating a piece of meat and down. So we have some of this. We have mild airway obstructions. The victim still getting small amount of air. The victim will be able to cough. If you find someone who has choked from something and they are talking and they can cough, don't tell them not to cough. Encourage them cough more and more and more, because as much as they cough, that is how they will try to they can be able to get the object or the foreign body out of their airway. Then here we have the infants. We know we don't choose what happens in our daily life. You can be able to go to, this is what we're trying to do. You can be able to, and you can use these techniques. Number one, if the kid is choking, you can confirm by what if the kid is really choking. Remember what we said? Check if they are breathing. If there is no breathing, you try to assess their mouth. You try to open their mouth and see if they're clinically obstruction. Then number one, when you're doing, you give 5 back slaps. 5. You hold the neck or to the chin. You hold the chin of the baby, and you bend them downwards, and then you do behind at the shoulders, where the shoulders meet. You always have that group. You give like 5 back straps. Then remember to support the infant's head and neck. And that's why we are holding at the chin. And then you can put them on your knee. You can be either seated, you can be have one knee kneeling, and then you support yourself with that. So for foreign bodies, air obstruction, irresponsible infant, check for expelled object. If not present, continue backstrap. After with the backstrap, you can check if the baby has, or if the object has come out of the patient body. If not, you change the patient, you change the infant or the baby. Now you put them on the other hand. Remember we said you support the head and the neck. Let them lie flat on your hand. And then check for the object. If it hasn't, you give 5 chest thrusts. So if the object still does not get out, you change the position and then you continue. Any question to that point? This Mike?
Yes, sir.
I'm waiting for a question. Do we have questions?
Yep, we can get ready to take some questions here.
Yes, sir. Yes, sir. Yes, sir. We should.
If anybody's got any questions or comments about today's training, we always, of course, encourage everybody to improve their skills and get formal certifications for medical training. But we also realize that there's situations where you may be presented with medical emergencies and you don't have someone trained in EMS to be there with you. So we're trying to provide some of this information for you to be better prepared to help save a life if possible. Looks like we do have a question. Let me change some settings here. Raphael, go ahead and unmute yourself and go ahead with your question. Oh.
Yes, my question is on. I've been told that we should put the casualty into recovery position, maybe probably on the left side. Maybe why is it on the left side? Because in most cases, we put the casualty. We put the caution to within the right side. Yeah, why is it on the left side?
Yeah, sure. Thank you so much, Rafael, for that. And the reason why we always advise or advocate for you put the victim or the casualty on the left side is, remember, the heart of a human being tends to slide or tries to get much bigger on the left side. So the light lung is always a little bit bigger than the left lung. So if you light them on the right and they have difficulties in breathing, it means you're trying to congest their room for getting more oxygen. That's why we always advise for them to lie on the left so that they can use more the light lung, which is more bigger, so that they can be able to get more oxygen to their body. Now, someone else had asked the same question on the chart. Lafayette, have I answered your question right?
Other questions anyone may have, now's the time. You can use the raise hand feature. You can unmute yourself and ask a question. You can wave at us on the screen. Raphael, you got another question?
Yes, I just have a question on still during airway obstructions. We normally perform for a child. We normally perform the chest thrust that the Mwalimu said. Whatever you came across, it's not on a handout, and you also want to perform abdominal thrust because you want at the end of the day to remove that object out that is obstructing the airway. Because the choking, you cannot know is it a mild choking or is it severe. How will you do to a child?
Okay, yeah, I'm assuming you're talking about a school-going child, or we call the toddlers. These are babies that can be able to stand, or they walk, and you cannot be able to hold them through the knee, or you cannot be able to support them. What you do, you kneel behind the child or the toddler. Then you can, now there it's when you perform the abdominal thrust. You need behind, in simple terms, you have to go down to the same level. And then for I find most of these people, and they are trying to tell you, they can be whispering and shouting to their top. That they can be coughing, they're fully coughing, like they are coughing literally, and then they are telling you, like, I feel like my airway is obstructed, or I feel like dog. So that's what you do. So what you do, you kneel behind the child, and then you can perform what you call the Heimlich maneuvers, or the abdominal thrust. What you do, you only control the amount of energy that you're going to use. You don't, you have to control, because if you use much force, like an adult, you might end up causing more harm to the kid. So you limit the amount of energy that is there that you're going to use.
Thank you. I've been answered. Thank you so much.
Someone is saying we repeat the answer to the first question. This is Amin Fatil. This is what we said. In human, the chest cavity, it carries the heart. It also carries the lungs and major blood vessels. So the heart of a human being, it curves, or it tends to lean more on the side of the left. So the left lung is always little smaller than the right lung. So that's why we make sure, like, this is why we are advocating for, let the patient lie on the left side and rest. Otherwise, on rest, it is not, it's not okay. So thank you for that. We continue. You are welcome for that. Jose, today is your time to ask questions. Now you're asking a question. He's sleeping in class.
Me asking a question.
So you are listening. Good.
Yes, I was. Feel free to ask any question. This is your time. It's actually the first lesson on first aid ever since we started this session. So I truly appreciate you, Richard.
So maybe I can pose a question to the panel or to everyone. How would you do a Henry or the abdominal thrust for a pregnant lady or an obese human? Yeah, anyone can answer it. Anyone, either on the chat, you can unmute yourself, and then we can talk about it. We can have a chat about it.
There's an answer on the chat.
Yeah, sure. You do good. They said you do chest thrust. We have a question on about how do you differentiate between an asthmatic arrest and choking? Number one, the major difference, or the number one that you can be able to differentiate the two of them, is for an asthmatic arrest or for any asthmatic individual or patient, they will have a prescription of what they do. You will find them either carrying inhalers. They can be, they always have inhalers. And the history of that victim or the patient will tell you their history. For choking, they will tell you. You also know. Number one, we said we have the normal, or what you call the classic sign of choking. You'll find these patients holding their neck, and they will tell you like they are choking. They will hold their neck, trying to cough, and then they will tell you, yeah, I'm choking. Or they will give you signs. But for asthmatic attacks, they'll have prescriptions. And if you have your stethoscope, and you can be able to use them well, you will remember what we call, you will listen. You listen to the lungs, to the lung sounds. For asthmatic patients, they will have sounds. They'll make some, when they're breathing in, they will bring some sounds, and when they're breathing out, they also produce some. For choking, if you listen to a stethoscope, it is only the airway that is obstructed. So for the lungs, they will be clear. So have I answered? Those are some of the classic differentiation on how you can differentiate the two.
Richard, is it common there for folks that have a medical condition like that to wear a bracelet that identifies their medical condition? Is that something that it's somewhat common here? If folks have a severe medical condition, they'll wear a bracelet that they call it like a medical alert bracelet. Is that something that you guys run into?
Yeah, it is very rare. For me, in my time, I have actually come across two or three cases for that. Because but what I've seen in most of these patients, they will have medical cards. Some of them will have medical cards. And if you check, you can try to, you're not actually going deep to get money on their pocket, but you're trying to check for some of these medical cards. They'll have medical cards. They'll say, if you find this in me, I have this. I had a friend who had a medical card for epileptic. He was epileptic, so he had that. So in everything that happens, it's always good. Then the other thing that is very important to us as firefighters and first responders is we need to be checking. We need to do sample history. We need to check. We need to have what do you call it? We need to ask. We need to have a way to communicate to our victims, and also you can ask the bystanders, like, what do you think these patients have? What do you think this victim? Because 90% of these individuals that we have around, they know each other. So you always find it very, very, very effective. You do the sample history. You can try to ask them if it has happened to them prior. Do they have any medications? Do they have any allergies? They will tell you. They will tell you. We have someone else who are trying to explain the same. For talking patient, you will find them trying to cough when they are grabbing their throat, and they will be very restless. For asthmatic patients, you'll hear them cough very frequently and cough continuously. They have wheezing sounds on their when they're breathing, and yeah, that's very good. Thank you so much, Jason Kimoro, for that. That was nice.
Question in the chat about what may be affecting a person who, whenever they start running, produces loud breathing sounds or sort of exercise-induced breathing troubles.
So for me, number one, I would say these guys, they need to seek medical attention. They need to go to a definitive care, that's a hospital, so that they can be able to be diagnosed. So that for us here, we are not trying to diagnose, we are not trying to treat, we are trying to learn how we can be able to identify. And then this is something that we always advocate in first aid and in EMT or in anything. Like everything that happens, please that person visit a hospital. We are not treating. So for them, I might have so many things or so many conditions that they might have. They might have asthma, they might have tuberculosis, they might have OCPD, they might have a lot of things. So it's good for them to visit the hospital so that they can get relief diagnosis, and then they'll get medication for the thing.
Our big goal is to try to render aid to those immediate symptoms that they're experiencing, and arrange for transport to better care. Yep. Other questions regarding today's topic or anything that you've heard today? Go ahead, Raphael.
Yeah. Where can we get the notes? Quite, we also need to make a review on the same to understand how much better.
Raphael, we're not quite getting your question there. Can you try to ask that again? Try to speak a little louder. Or go ahead and add your question to the chat, and we'll get to it that way.
Chief Mike, I think I understand, like he's trying to ask on the notes, if they are going to find the notes. Yeah, sure. We are going to share the notes in on the website.
Sure. Yep. Send your presentation over to me. I will post it. I'll post a link now, and we'll get this up later on today or tomorrow. The link I just posted in the chat is our Google Drive folder. You can also access this from our website, www.africafiremission.org. And if you go on to that site and go to resources, all of our training resources and things are available there for you as well. At this point in time, I'm going to wrap up the formal portion of our training today with a thank you to Richard for joining us, he's working in the dark and through those internet issues, but we still got a great training session in. Thank you, Richard, for the sacrifices that you got to make to get this work. Much appreciated. And thank you to all of you for coming and joining us for today's training session, trying to better yourselves, get some more knowledge so that you can better serve your community and your fellow firefighters. We're very appreciative of that. We've got plenty of extra seats here in class, so please invite any colleagues that you may know that aren't here and aren't attending. We've got room for 300, and we'd like to see those all filled up, so please be sure to share that registration. If you don't know where to find that registration link, once again, send your friends to africafiremission.org, and there they can find a place to register under that resources tab where you can register for our training. You can find our community fire prevention resources. Lots of free materials there that we've provided to try to help all of you out in your jobs throughout Africa. Thanks, everyone, for joining us. We're going to wrap up the formal portion here and see you all again next week.